तो टाइफाइड आया है।
So a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all once again to our ACTRAC Head and Neck academic classes. Our today's speaker is Dr. Vasundhara Patil. Dr. Vasundhara is Associate Professor in Department of Radiology, Tata Memorial Hospital, Mumbai. Dr. Vasundhara is not only a very renowned radiologist, she is also a renowned painter also. I think that we'll discuss later on. And today she will be speaking on the topic, the radiological anatomy of salivary glands. So with this, I welcome Dr. Vasundhara. I think Dr. Vasundhara, you have joined. You can share your screen.
Yes, ma'am. Thank you, ma'am, for the invite. Now I'll share my screen.
Yes.
I can share the screen.
Uh,
Yeah, got it.
Yes.
Is my screen visible?
Yes, it is visible.
Put it in the, yeah, just a minute.
Yeah, please make it on in this. Yeah.
Very good morning to everyone. I will start my talk about the radiological anatomy of salivary glands. So this is a talk from a radiologist to a surgeon, basically. So I will limit myself only to the practical part of it. How do we see the scans? I will not discuss theory at all. So and I will try if the fat content is high. Now the posterior relation, if we see, there are certain structures which indents the posterior part. One of them is this mastoid tip. There is the styloid process. The lower part, we will get the sternocleidomastoid muscle and the posterior belly of the digastric. Anteriorly, the superficial lobe lies on the ramus of mandible and the masseter muscle. Medially, the deep lobe projects inside through this stylomandibular tunnel. Now, the most important thing for you all is the facial nerve. So how do we trace the facial nerve? If you scan from above, you will get this mastoid tip. If you look medially from it, you will get this styloid process. Between these two is the mastoid groove. And in the groove, you will see a dot like this, which is the facial nerve. If you see on the left side, the mastoid tip, the styloid, this is the groove, and you will get the facial nerve. Trace this facial nerve laterally, and you can very easily trace in all the patients till this retromandibular vein lateral to it. So this part of the facial nerve is seen in almost 100% of the patients on MRI. And the sequence that you will choose is a thin T2 or a T1 weighted image if the fat content is very high. If we see on this side, the mastoid, the styloid, this is the groove. Higher up, it will go into the stylomastoid foramen. Trace the nerve. This is the nerve coming here, going lateral to this retromandibular vein. After this, it branches, and the branches are difficult to see. So that is how we trace this part of the facial nerve. Rest we will discuss later. So lower part, the gland obviously reaches up to the angle of mandible. So three nerves are related to the parotid, the facial, the auriculotemporal, and the great auricular nerve. This is important to you all for the graft, but we don't see it clearly. These two we will discuss in the talk. Now, this is a T1 weighted image. Previously, we had seen a T2. But for parotid, the T1 weighted image is also very, very important because it is a fat-containing structure. So the gland is very well seen even on a T1 weighted image. Now just look, this is the mastoid, this is the styloid, the mastoid groove, and this is the nerve. So even on a T1 weighted image, it is seen very well. Similarly, on the opposite side, the mastoid, the styloid, this is almost reaching to the part of stylomastoid foramen, and this is the nerve. Trace it laterally and you will see in all the patients this nerve. See. Similarly on this side. So at least after this talk, I think every one of you will be able to trace this facial nerve on MR. See this one. Now you will understand. So now, once you know the facial nerve, you know whether your lesion is superficial or deep to it. Okay. So both on T1 and on T2, you will be able to trace your facial nerves. At least the part that comes out from the stylomastoid foramen till the retromandibular vein. Now we know that the parotid drains to the Stenson's duct, and there is also something known as an accessory parotid. The contents we will see, there are nodes, retromandibular vein, and the ECA. So duct, how is the duct seen? The duct is not seen within the parotid. It is seen outside the parotid. Only when it is dilated, we see the duct within the parotid. So this is the duct which comes out, takes a 90-degree bend and opens opposite this second molar, upper second molar. You will see another structure coming anteriorly. This is not the duct, this is a zygomaticus major. So want to see the duct come anteriorly coming, taking a 90-degree bend over here. This is the duct. This was a case when there was an accessory parotid which got inflamed and there was a lesion over here. Just to show that this part also may contain a lesion. This was a pleomorphic adenoma with lot of inflammation in the superficial duct, probably because of repeated palpation by the patient. Coming up, which scan to do? So see, whenever in a normal setup, if the patient comes with an acute pain, acute swelling, or a recurrent episodes of swelling, when a calculus is suspected, a plain CT is enough to rule out a calculus. That time, MR may not show a calculus very well. If the patient comes with a hard swelling, painless swelling, then an MRI should be done, because if a neoplasm is suspected, MRI is the modality of choice. What should our report contain? Obviously, the location, whether it is going to the deep lobe, any extent to the parapharyngeal space, adjacent structure like EAC, the TM joint, and the nerve involvement, and probably what is the etiology or the histopath that we think it. Now, MRI is not very good, or radiology is not very good in telling whether it is benign or malignant, and what, because benign lesion with normally has a very well-defined capsule. It looks very smooth, but all our low-grade malignancy will also behave like this. Similarly, high-grade malignancy has very irregular and infiltrating margins, but a benign lesion which has got inflammation like we saw previously, they may have an ill-defined and a very irregular margin also. Similarly, what low-grade tumors, they are usually bright on T1 and T2 because their secretions are maintained. They secrete some amount of serous or mucinous product, and they have a high cytoplasm to nuclear ratio. So they are usually T2 bright. Whereas a T2 dark tumors are expected to be more malignant because first of all, there will be no secretions within them. And secondly, there will be very high nuclear to cytoplasmic ratio. So this is a general rule that we follow while looking at a scan, whether it is benign, well-capsulated, or an irregular marginated, whether it is T2 dark or T2 bright and restricted diffusion. But still, final diagnosis will depend on histopath. So I will not go into the types of tumor. I'll just look at how we report the tumors. Now, this was a case in which there was tumor in both the parotid. So if you find a well-defined tumor in a parotid gland, the first one take-home message is please look at the opposite gland. We may be dealing with a Warthin's tumor, especially if it is a male smoker and a little old, around older age. So first take-home message, look at the opposite parotid if you think the lesion is relatively well-defined and looks benign. Now this was a case of Warthin's tumor involving both the parotid. A tumor which looked very similar over here, this was a mucoepidermoid tumor. Hence, I say we do not rely on histopath, we cannot tell the exact histopath on MR. Now, this is another scenario when there was a diffuse enlargement of the gland and the lesion involving the entire gland with a maintained shape of the gland. So if the tumor is involving the gland but maintaining the shape of the gland, a relatively homogeneous tumor, it is a lymphoma. So salivary gland which is enlarged but maintained in shape, we are probably dealing with lymphoma. Next is role of CT or MR. The parotid has a very high fat content. So in CT, if it is very fatty, then also we can see the lesion very clearly. And if you start tracing the facial nerve in such fatty parotid, we can trace the facial nerve even on a CT. And this was a very fatty parotid on a T1 weighted image. Now, what is the role of sequence? Which sequence we should give importance while looking at the parotid? This was a mucoepidermoid tumor on a T2 weighted image. We can hardly see the margins of the tumor, probably because there is secretions within. The tumor is T2 bright and now it is not well differentiated on the adjacent gland. Whereas if you see your T1 weighted image, the lesion is very well seen. So many a times in parotid, I would like to look at my T1 weighted image for the extent of the tumor rather than a T2 or even on a post contrast. I am not sure how deep it is extending. I would rely on my T1 weighted image in these cases. So for parotid, T1 weighted image is equally important than T2 or a post contrast image. Now, which planes to look at? Obviously, we all look at the axial plane. But to comment on certain structures, I would also like to look at my coronal and sagittal image. Now, this is a sagittal image. There is a tumor in the parotid. If you look at, this is the external auditory canal. The external, whenever a structure is cut in cross section, in radiology, that plane is the best plane to evaluate the image. So when my EAC is cut in cross section, my SAG becomes the best plane to tell my distance from the EAC. On axial, we will get an averaging. So this, we can see very clearly the EAC was not, the ear was not involved. Now, as you come to the TM joint, this capsule is also very well seen. So sometimes for the TM joint also, whether it is an ear malignancy or a parotid malignancy, I would like to confirm on my sagittal image. Obviously, we do look at the coronal also. So apart from axial, we look at our coronal and sagittal images for certain structures like TM joint, the EAC, and also the cranial extent of the facial nerve. So we have looked at which sequence to look at, which planes to look at. Now coming up to the lesions individually. So this was a lesion located in the superficial lobe of the parotid gland, touching the ramus, lying on the masseter. It has some relation with the EAC. This is the facial nerve and it was completely outside the facial nerve. Okay. Now the second lesion we will look. So this was a very clear-cut lesion of the superficial lobe of the parotid involving the skin. Now this was a tumor which was now going deeper. So this is the facial nerve. It was coming like this. Obviously the lesion is extending deep, involving the retromandibular vein and the deep lobe of the parotid. It was abutting the EAC, probably looked involved on this. Looked at my SAG image, it was involving the EAC. The tumor was also going medially. So the extent of the parapharyngeal extent should also be looked at. I will tell you what happens over here. And there was no definite enhancement along these nerves. So for deeper extent, whether it is going deep, involving the facial and involving the adjacent structures, we look at this. Now this was an adenoma of the deep lobe of the parotid. Here the question comes whether it is a parapharyngeal space or the parotid space. Usually it is difficult to tell in all the times, but in this case, like this fat was preserved. Had it been a tumor arising from here, it would have engulfed this fat and then extended over here. So this was a parapharyngeal space lesion. The fat is very well preserved and pushed. This tumor is just over here. This was a tumor from the deep lobe of the parotid. And obviously the tumor from the deep lobe of the parotid also causes widening of this space, which is the stylomandibular tunnel. So we should always look at the styloid process, the widening of this tunnel, to confirm it is a lesion from the deep lobe of parotid. Now this lesion was again over here, a very large lesion in the parapharyngeal space or the parotid space, not very sure. This was causing widening of the stylomandibular tunnel and completely obliterated the fat of the parapharyngeal space. But at the same time, the way it was displacing the carotid, it was like pushing the carotid laterally and out, and also insinuating between the styloid process and the posterior fascia. So a tumor from the parotid would grow like this, but this tumor has a force which is pushing behind. So the first, I would like to think that it is a parapharyngeal space lesion rather than a lesion from a deep lobe of parotid. And your incision varies according to this. So depending upon the displacement of the styloid and to push on the carotid, we can tell whether it is from the parapharyngeal or the deep lobe. So this was a lesion extending right downward till the submandibular. This was again a lesion of the parapharyngeal, pushing the carotid out and displacing the parotid also. Now coming to another lesion, which was involving the deep lobe of the parotid and extending medially. So what was the lesion exactly? Whether it was a deep lobe of the parotid or the parapharyngeal. Parapharyngeal is maintained in this case. But the first thing to confirm for the deep lobe of the parotid is where is my styloid process? In this case, the styloid process was displaced anteriorly, and this is the muscles of the styloid process. So if the styloid process is displaced anteriorly, this is not at all a parotid lesion. This is a lesion from the post-styloid. It was extending superiorly and involving the skull base. On CT, we saw that there was some calcification, and it was actually a chondrosarcoma from the skull base. So while saying it is a parotid lesion, first checklist would be look at your styloid process and see where is it getting displaced, whether there is widening of the stylomandibular tunnel. So here was the styloid. Actually, this tunnel was narrowed. It was pushed anteriorly and lesion was post-styloid. Now I had shown you the facial nerve outside the stylomandibular foramen. But when there is perineural, we need to comment on the facial nerve involvement within the temporal bone. So how is the facial nerve placed? It arises from the pons, goes into internal auditory canal over here. And this part is better seen on a T2 weighted image. On CT, this is the course of the facial nerve. It comes out through this tunnel, forms the first genu, and here it gives the branch of the Vidian nerve. Then it travels behind, this is the tympanic segment, takes the second bit turn over here at another 90 degree and comes down and continues as the mastoid segment and finally into the stylomandibular foramen. When we look at on MR, on our this thin MR, FSPGR, we see the facial nerve in all patients, 100% of them. So this is how we see the facial nerve. The anterior part is the facial nerve. Here is the cochlea. It will come out and take the first genu. This is the first tympanic segment and the first genu. And the nerve will travel over here, which is the deep petrosal nerve, go anterior to the carotid into the, to form the Vidian nerve over here. The rest of the facial travels behind. This is in the tympanic segment. It takes the first bend, that is the mastoid segment, comes down vertically as a dot in the mastoid segment. And if you see, and there is always the opposite side to compare if there is any abnormal enhancement. It will come down and come out through the stylomandibular foramen. After coming out of the foramen, it is not well seen on the post contrast, and then we start seeing a T1 and T2 weighted image. So combine T1 and T2 along with our post contrast, we can see the entire course of the facial nerve from the origin till the mandibular vein. Let's see an example. Again, this is the facial vein in this part, the tympanic part, and the mastoid part. Any abnormal enhancement, and compared to the contralateral side, we give the diagnosis of a perineural. This was a case of a very malignant, very T2 dark, and irregular lesion involving the superficial lobe as well as the deep lobe. If you see the post-contrast images, this was extending. This is the mastoid tip and the styloid. You search for your mastoid tip, go down, come medially, and you will find your styloid. And this is the groove. The tumor was extending into this groove. Now keep looking in this groove and go scroll up. As you will scroll up, you will enter the stylomastoid foramen. So this is the foramen. There was some enhancement that continued over here. Now this is the facial nerve. There was an asymmetric enhancement over here, which continued all along. This is the facial nerve. There was no such enhancement on the opposite side. It continued till into the mastoid. This is the mastoid part, which is not enhancing on this side. And now the tympanic part is normal. So there was a perineural extending into the groove. You trace the groove, come up, you will get the foramen at the same point, and come up, you will get the mastoid segment of the facial nerve. Did we miss something? There was also a perineural into the ovale. Now this part we will discuss. Where is this auriculotemporal nerve? So this was a lesion which had lots of perineural going up to the ovale. This is how the lesion from the parotid gives a perineural medially into the mandibular nerve, and this is the auriculotemporal nerve. Now and there was also a perineural anteriorly into the buccal nerve. Let's understand this auriculotemporal nerve. So the mandibular nerve comes out through this mandibular foramen. This was a case when we get a perineural, we understand the anatomy so well that it is only when we understand the anatomy in cases of perineural, we start looking at the normal scan. So this was a thickened mandibular nerve over here. This mandibular nerve was going all along into this mastoid, and there was a perineural. So this was, into this parotid lesion. So a parotid lesion, when it comes medially and comes into this parapharyngeal space, you also look at whether there is a perineural medially into the mandibular nerve, or ask your radiologist whether there is perineural not only in the facial, whether the fifth nerve is also getting involved. So this was a perineural over here going to the auriculotemporal retrograde, and it was also involving the inferior alveolar and the lingual. So now look at the anatomy. What happens to the mandibular? The mandibular nerve gives an anterior branch which is small and supplies this muscle. The posterior branch is what we see on MR. This posterior branch divides into three nerves. That is the lingual, the inferior alveolar, and the auriculotemporal. This lingual will then cross these pterygoid muscles, same as the inferior alveolar, but it travels little anterior to it. So these are the two, lingual and the inferior alveolar. It will travel anteriorly. This goes behind and comes over here, whereas this travels anteriorly, reaches the ramus of the mandible, and then travels in the lingual groove. Same over here. This was a perineural which was then antegradally involving the lingual. So lingual thickened, inferior alveolar thickened, going down. This is the lingual and the inferior alveolar. Another case of a buccal carcinoma, just to show you the perineural. A large buccal carcinoma was extending behind. I was not sure whether it is along the parotid duct or there was a perineural, but the enhancement was extending right up to the parotid, and there was a nerve thickening over here going to this mastoid groove. So it was a perineural along the buccal branch coming to the parotid and into the facial nerve. So parotid also becomes very important in our cases of buccal carcinoma to check for any lymph node enlargement or a perineural over here. At the same time, this is the auriculotemporal nerve thickening, which was going into the, mandibular nerve. So this was about the parotid. Now coming up to the submandibular gland. There's not much, but I'll tell you the anatomy of the submandibular gland. We know there is a deep lobe and a superficial lobe, which bends over the mylohyoid. So the submandibular gland is located in the submandibular triangle. There is the belly of the digastric, which is in relation to it. It also lies on the mylohyoid and the hyoglossus behind. And the ramus of mandible is lateral to it and also related to the medial pterygoid muscles. This is, once you start seeing the scan, this is the mylohyoid and this is the hyoglossus muscle. The mylohyoid covers only half of the floor of mouth. Over here, the submandibular gland will turn over it and enter into this space. And the duct passes between this mylohyoid and the hyoglossus to open in the space medial to the lingual gland. This was the axial anatomy of the submandibular gland. Coming up to the coronal anatomy, inferiorly lies the platysma and the fascia, the belly of the digastric muscle, the mylohyoid, and posteriorly the hyoglossus. So these are the medial relations of the submandibular gland. The lateral relation is the ramus of mandible and the medial pterygoid. Now this is the space which is the parapharyngeal space. The parapharyngeal space extends inferiorly into the submandibular space. And there is an oblique muscle over here, which is again very important. This is the styloglossus muscle. Now this styloglossus muscle, some believes that the parapharyngeal space closes over here. So this styloglossus muscle is also very important. When you see a large bulky tongue, you see whether the tongue is extending into the parapharyngeal space or along the styloglossus muscle over here. So if you want to look for your styloglossus muscle, look at your coronal image, go above the submandibular gland, you will find this muscle. This muscle is also important because there are nerves over here, the lingual and the hypoglossal nerve. So enhancement medial to this muscle, I look for any enhancement to check the perineural because these nerves per se are not easily seen. So perineural going beyond the tongue, I take this as a landmark to understand that. You will see them very clearly in all the patients, the styloglossus. Coming up to the facial nerve. Now the anterior facial vein is in very close relationship to the submandibular gland, and it drains into the external jugular. What is the importance radiologically? If there is a gland which has enlarged, this facial nerve will be present between the gland and the submandibular gland and the enlarged node. Whereas if this vein is getting displaced laterally, that means the lesion is from the submandibular gland. Similarly, you have a facial artery in close relationship to the submandibular gland. The facial artery originates from the external carotid, takes a U shape, goes inferiorly, and then travels on the lateral surface of the gland. This is the sag-mip. The artery is arising from this, taking a U-shaped bend. It will come down like this, take another U like over here, and is in relationship with the lateral aspect of the submandibular gland. So the vein is mainly used as a checkpoint to know. Now this was a lesion over here in very close relationship with the submandibular gland. This is the vein and this is the lesion. So if the vein is present between this, I know I'm dealing with an enlarged node and not a submandibular lesion. Similarly, the vein was displaced laterally. This was a lesion from the submandibular gland. Now, perineural in cases, they are very, very rare, but I found a very interesting case. This was a tumor of the submandibular gland, which was treated with RT and later recurred and involved the mandible. Looking at this, there was some structure. There was a palsy of the hypoglossal. There was a tongue palsy over here, and the muscles of masticator had atrophied. Some structure was coming over here apart from the inferior alveolar nerve and joining this nerve to form a thickened perineural over here. So what was this? Now let's trace carefully. This is the structure coming out, coming over here. Then it will cross the pterygoid muscle. It will go between the lateral pterygoid and the tensor muscle and finally join the mandibular. So this is the course of your lingual nerve. Divide from the mandibular, go between the tensor and the lateral pterygoid, cross the lateral pterygoid, it comes anteriorly, reaches the angle of mandible, and then travels in the lingual groove. This is the anatomy of the lingual nerve. Partly, in parts of it, it is seen in all patients on CT and MR. So this is the normal. If we try to trace it on the left side, this is the lingual, this is the inferior alveolar, this is the auriculotemporal. Sorry, I'll go back. It will cross this, come over here. Partly it is seen, at least the perineural, if involved, will be seen. Sublingual gland, I'll just talk about the anatomy of tongue and the floor of mouth. Now we know the sublingual gland is situated in the floor of mouth. Sometimes you find a very weird report when you feel the floor of mouth is involved and we write it is not involved. This is because the radiologist and the surgeon speaks different language. For the radiologist, floor of mouth is the mylohyoid, whereas for the surgeon, the floor of mouth is this mucosa. So this mucosa is actually, this is the oral tongue and this is the floor of mouth for the surgeon. So the contents of the floor of mouth laterally will be the sublingual gland, medially will be the root of tongue. It will partly the root formed by the genioglossus and the geniohyoid complex. So posteriorly is the base of tongue. This is the oral tongue and this is the floor of mouth. How do we see the sublingual gland? The sublingual gland is present in the lateral aspect of the floor of mouth. It is well seen on coronal, sagittal as well as axial image. So on sag we see it like this. Now this, to understand whether the lesion is located to the floor of mouth or going to the oral tongue becomes little difficult for us because the oral tongue sits on the floor of mouth and radiologically we don't have a much distinction between these two. So how do we see it on axial? This is the mucosa, this is the oral tongue and this is the floor of mouth. We just see a thin line which is probably separating these two, but this is also obliterated if there's a lesion over here. As we go behind, this is the anatomy, and then we enter the further posteriorly we will reach the base of the tongue, that is on the coronal image. Sagittal image, I'll just tell you the anatomy of floor of mouth. The sublingual gland is there. The lower part is the geniohyoid. As we go up the geniohyoid, we'll start seeing the genioglossus. The lateralmost muscle that we see, the dark line, is the mylohyoid. The medial one is the hyoglossus. In between lies the part of the sublingual gland, and the submandibular gland will also insinuate over here. The muscle which goes laterally like this is the styloglossus muscle. Now let's look at the anatomy on axial. And this is the sag correlation of the axial. When we are up at this level, we see the oral tongue, and this, the circular muscle, you see the faint circular muscle like this. This is the oral tongue and this is the base of tongue. Some people take this as a demarcation line from the junction between the hard palate to the soft palate. Anything anterior to this is the oral tongue and posterior to this is the base of the tongue. I personally find this circular muscle better to understand the oral tongue and the base of tongue. As we scroll downward, see the posterior part is the base of tongue. In between, we are seeing a small component which is the oral tongue. And then we are seeing the anterior part which is the floor of mouth. So axial image, all these three comes together. As we go further down, this is the floor of mouth, maybe the little part of oral tongue, and this is the base tongue that we get. The hyoglossus, the mylohyoid, the sublingual gland, and the submandibular gland. And this is probably the styloglossus. Further down, now there is no oral tongue. All that we are seeing is the base of tongue, and anterior to this is the floor of mouth. Further, this is the base of tongue and this is the floor of mouth. So depending on where you are, we will see various structures cut in axial, that is the base of tongue, which is very easy to understand by this circular muscles. The floor of mouth and the oral tongue comes together on axial images. Now this was a case of carcinoma ACC of the right sublingual gland. There's not much to teach about it. Just to show you, and a large tumor. This was a mucoepidermoid from the left sublingual gland, and see the oral tongue is entirely uninvolved on the scan. It is only arising from the floor of mouth, going inferiorly and extending out. Okay. Now, minor salivary gland. These minor salivary gland are submucosal, small clusters of cell in the submucosa, and they are present in the oral cavity, palate, paranasal sinus, pharynx, larynx, trachea, bronchi, lacrimal gland, and ceruminous gland. So the tumors of this we find at all these places. In the oral cavity, they are in the palate, lingual area, labial, buccal, and the retromandibular area. Imaging of these tumors are very, very non-specific, but they enhance like this on the scan. So sometimes they mimic like a tumor, or it gives us a false positive what is happening over here. So these are the typical appearance of these submucosal glands which are present. They may be present in the tongue, in the buccal mucosa like this, posterior tongue. They are always present in the RMT as well as in the palate. We'll just look at an example. This was a case of carcinoma tongue which was extending behind, and on this scan it looked like it was extending into the retromolar trigon. Obviously, you know it much better because you can see the patient and understand it was not going over here. But for us, there was an enhancement that was extending all along into the RMT. But whenever I have to report my tongue to report that it is extending into RMT, there is one sequence I will look at, and that is my T1 weighted image. It will never be my T2, it will never be my post contrast. So in T1, you see that this area has fat. There is no tumor over here. The tumor was dark and very well stopped over here. So what was this? This structure is the minor salivary gland, always present in the retromolar trigon, see this area, which gives an enhancement like a tongue carcinoma, and the same signal on T2 weighted image like a tongue carcinoma. So a T1 weighted image is very, very important to report the retromolar area in cases of tongue carcinomas. Then again, I also use my T1 weighted image for my palate lesion, because palate also has a lot of submucosal fat. So wherever there is fat present, the T1 weighted image becomes important to understand the depth of the disease. One more, this was extending all along over here on a T1 weighted image. Now, palate lesion also have lot of submucosal glands. So for when we report palate carcinomas, we not only look at eggshell and sagittal image, but our coronal images also becomes very important to tell about the bone erosion or a perineural. So where do we look for perineural in a palate carcinoma? There is this palatine foramen behind. You will see this foramen on CT as well as on MR. See for any tumor extension, this palatine foramen will go up and it straight continues as the pterygopalatine fossa. The pterygopalatine fossa has an opening medially into the sphenopalatine, the pterygomaxillary fissure, and this fossa itself continues into the inferior orbital foramen. Okay. Now, how do you trace your foramen rotundum and Vidian canal? This is always a problem. So how do I teach my students? You see this McDonald M. You look at your nasal cavity, keep scrolling behind till you see this bony structure, and I call this as McDonald's M. When you get a McDonald's M, these are its ears. Come to its ear, you will find the Vidian. Come diagonally opposite, you will find the rotundum. So if you want to know the landmark, look at your nasal cavity, keep scrolling behind till you get this bony bar and the McDonald's M. Look at its ear, your Vidian nerve your Vidian canal will be there. Go diagonally opposite, your foramen rotundum will be there. This is another foramen, not very important. This is palatovaginal, but it does takes the perineural from the roof of nasopharynx. So this is how to trace your Vidian and rotundum. Now you will find them in all your patients. So just the eggshell anatomy. This was the hard palate. Coming over here, the palatine canal. Keep tracing your palatine canal, the greater and the lesser. You will yourself enter into the pointer will itself enter into the pterygopalatine fossa. Keep traveling up. The pterygopalatine fossa will open medially into the nasal cavity. Laterally will be the pterygomaxillary fissure. Keep scrolling up. There will be a Vidian, this Vidian canal going straight up into the like this, and a little medially will be the rotundum. Rotundum is actually difficult on eggshell. Straight will be the vidian, which will open into this lacerum. This was the palatovaginal. Keep scrolling up, and this structure that you enter is the inferior orbital fissure. So that is how we look at perineural for the palatine. I think this is all I have made for my talk. Thank you.
So thank you, Dr. Vasundhara. Excellent lecture. I think seeing the nerve anatomy, it is always a very challenging and difficult thing for the surgeons. I think for us, it is seeing a dot also is enough. We get excited, but to learn from you the whole sequence, how the nerve goes, is really great. So I think, Dr. Vasundhara, there are, I think, couple of questions on the chat box. If you could take them. So
Yes.
one is, yeah, have you ever seen the SCC of salivary glands? Which is obviously yes. And can imaging help in the pre-op period?
Imaging only helps in the extent of the disease. For the pathology, even I don't rely. I don't want to make guesses. We are not correct most of the time. So for any extent of the tumor, the imaging will help. And it was an SCC of which gland?
I think SCC of parotid is not that common, but we do see SCC of parotid also. So I think that was the question. I assume you can post again, Dr. Anmol, if you have any question. Submandibular gland, it is also not very common, but we do see once in a while. Being a tertiary care center, I can tell you that we see squamous cell carcinoma of all the glands. In fact, we have seen submandibular as well. Yes, Dr. Vasundhara. Hello.
Yes. Yes, ma'am.
So yeah. So
question, please show the facial nerve course once more. Okay, I'll show. And tongue, especially in coronal image, which this is submandibular gland.
Yeah, we can take one by one, Dr.
Okay.
Yeah. So if you show the facial nerve course, I think it is, like I said, it is difficult for us to understand it. It would be great if you could show it once more.
So facial nerve outside the canal, how do we see it? Now, how do you go about? You come up to the EAC, start tracing your mastoid. Once you go down, this mastoid will form the tip. At that level, come medially, you will find this bony structure, or look at from the tip medially, you will get this bony structure. And there will be a foramen over here. The tip medial to it, you will find this dot, which is the nerve. So go to your mastoid tip, search for your styloid. Between these two, you will get the mastoid groove. And in the upper part between these two, you will get the stylomastoid foramen. Even if you don't get your styloid, forget it. You will get your mastoid tip for sure. Look medially for a dot like this. That will be your facial nerve. Trace it laterally. This nerve will be seen as a dot coming all along. Once you start tracing, now you will see it in all your patients, and it will become very easy. See, this is mastoid tip coming medially. I see this dot. I know this is my facial nerve. Trace your nerve, and you will come up till here. After here, now it starts branching, and those branches becomes difficult. Only when there is a thick perineural, we very well understand these. So now you see any image, go back, go forth, you will see these nerves. Okay. If you find any, now forget about the temporal part. If you find any enhancement over here, keep looking up on your post-contrast sequence to see whether your enhancement is going up in the temporal part. Is that fine? Should I teach the intratemporal part also?
Yes, Dr. Vasundhara, please.
So this was, just imagine this is a T1 weighted image and we can see the nerve so well. Same happens with a T2 weighted image. Any scan you take and you will be able to see the dot. See this dot. Now, the part of the facial nerve that is inside. This part we see on a T2 weighted image, the cisternal segment, as well as on post contrast FSPGR. Open that sequence, you will see this non-enhancing structure, thin structure coming up. This is the cochlea. This will come up and take a 90-degree bend behind. This is the labyrinthine segment. At the same time, this part is also seen in all the patients. This is the deep petrosal nerve, which will then form the Vidian, anterior to the carotid, come out through the Vidian canal. Now, this nerve you trace posteriorly. It goes behind like this. This is the tympanic segment, takes the second genu and then travels down. You will see them on both the sides very well. Look for any asymmetric thickening or enhancement in this part, and that would be your perineural. So this is almost same. There is on both the sides. So this also is very important to compare from the opposite side. Start looking downward as a dot till you will get your stylomastoid foramen. After that, now the nerve is not clearly seen on this sequence. We take our T1 and T2 as a reference image. Only when it is thick and there is a perineural, we see well on a post contrast, otherwise not the routine nerve. So coming here, come like this, then take a 90-degree bend. You will get your tympanic in all patients. Come down, it will see like a dot. As you go down, you will see that nerve till the stylomastoid foramen. Okay. Second question is, tongue and coronal, it becomes difficult to access the depth if sublingual gland is involved or not. We should look in T1 in all cases, like you said. You check both your T1 and your T2, because all these salivary gland tumors, now, they are sometimes so bright you cannot separate them from the rest of the gland on your T2. In that cases, your T1 becomes very important. So T1 is not a sequence to be ignored at all in cases of salivary gland tumors. Not in all cases. If you feel that your T2 is not giving you a proper delineation of the tumor from rest of the gland, look at your T1 or look at your post contrast. Parapharyngeal with a carotid relation. Okay. This is not something which is written in books, but this is what I have to do a study to validate this. Now, this is from the parotid. First of all, confirm your parotid. Look at your styloid. See that it is causing widening of this part. That means it is parotid. Now, how the parotid will grow? Parotid will grow like this. So what will be the push on the carotid? It will be like this. And at the same time, the styloid will be pushed like this. How does the parapharyngeal mass grows? Sorry. The parapharyngeal mass will start growing somewhere over here. So what will it do as it grows? It may push the styloid or it may grow behind the styloid. But a parotid growing will not come like this and go behind the styloid. So one thing, styloid being pushed anteriorly with a widening of the space may be a parapharyngeal. Secondly, if the parapharyngeal is growing like this, what will it do to the carotid? It will try to push it out. So a lateral displacement of the carotid may be a parapharyngeal tumor. But this is just my observation. I have to validate this point, but this is how I take it. And sometimes it is very difficult to tell it is parapharyngeal or deep lobe of the parotid, though your incision changes accordingly.
Correct. So I think in the parapharyngeal space, the deep lobe in fact comes. So it's really difficult to sometimes differentiate between the two, unless you can see a clear distinction between the capsule between the region and the parotid. Correct,
Yeah.
Dr. Vasundhara? So
Yes,
it is many a time it is difficult, right? I agree. I think there's one more question. I think it is more for me. If we encounter a T4 larynx and DL biopsy shows minor salivary gland mucoepidermoid carcinoma, how to decide for adjuvant treatment? Even though I would say here we were not discussing the treatment today, was mainly the radiological anatomy, but still I would say that whenever you treat a minor salivary gland tumor, especially a mucoepidermoid carcinoma, one thing is that these minor salivary gland tumors ideally have to be treated with surgical intervention. Second is that your grade of tumor is very important here, especially for mucoepidermoid tumors. As we know, they can be like uh, the uh, the high grade, intermediate grade, or the low grade. So usually in these salivary gland tumors, two things will be important. One will be the grade, and the second would be the extent of resection. So if you have done a good resection and your excision is complete and it is a low grade tumor, you can keep it under observation if there are no other negative prognostic factors. But if it is a close margin or there are other negative prognostic factors, like in cases of high grade tumors, especially, there can be nodal metastasis. In those cases, adjuvant treatment in form of radiotherapy can be considered. In intermediate grade tumors, usually there is some sort of controversy regarding, in fact, it should be addressed the neck or not. But for the low grade and high grade, I would say we can go ahead and do that. In fact, we can discuss it in one of the classes subsequently when we have a lecture. And I think I will restrict it right now to this only, because this is today is our this class for the radiological anatomy. So if there are no more questions, I would uh, once again thank Dr. Vasundhara for
Thank you.
such a wonderful lecture. And so thank you so much, Dr. Vasundhara. It was great learning, especially the facial nerve part, the skull base anatomy. It is not easy to understand, and you took so much of time taking out these slides and telling us in a very sequential manner. We are really thankful to you.
Thank you, ma'am, for giving me this talk. I would love to teach. Thank you, ma'am.
Thank you. Thank you, Dr. Thank you so much.